Hello, everyone, and welcome back to another episode of Just Medicine. Today, I have Dr. Maria Hubinette, and we are going to be chatting about trauma-informed care. Dr. Hubinette is a family physician who works with survivors of gender-based and sexualized violence, and she's also a clinical professor at UBC and the family medicine undergraduate program director. So she's very involved with medical education and mentorship for medical trainees. Dr. Hubinette, so great to have you on. Welcome.
Thank you. Thanks for having me.
Of course. And can you start us off by telling us a little bit about yourself and your kind of training trajectory and how you ended up here?
Sure. Yeah, thanks for asking. So maybe I'll just start with who I am as a person and then talk a little bit about some of the different kind of avenues of work that I've done related to this. So I'm a white cisgender woman. I'm the daughter of immigrants who came to Canada in the late 60s and kind of navigated life in Canada and decided to raise their family here. I live, work, and play on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh in the of what we know colonially as Vancouver, the southern part of Vancouver. I'm the mother of two teenagers and enjoy spending time outdoors and being out in nature is really important to me and for my mental health. I'm a family physician by background. I'm a UBC grad myself. I trained in what was then the rural family medicine program that we did a year, kind of a rotating year at the Royal Columbian Hospital, and then spent the second year traveling around in rural communities in BC, which was a wonderful experience. And I think gave me some insights into, just how care is delivered outside of an urban center. And just some of the other considerations in rural and less accessible parts of the province. And as you mentioned, I'm an educator. I did a master's of medical education about a dozen years ago. Once I realized that I needed to learn a lot more about how to teach and kind of all of the sort of pedagogy behind why we do things the way we do them and so on. And at that time also gained some skills in education research. So I've got a bit of a program of research as well, all kind of with an equity lens. And that is informed by and informs my clinical work and my teaching. And just feel really grateful to be able to do all of those things in the course of a busy life and career. So that's a little bit about me. And I don't know if there's anything specific you wanted to know about, please feel free to ask. Otherwise, I think hopefully that gives people a little bit of a sense of who I am and where I've come from.
For sure. No, I really appreciate all that you shared. And it's really wonderful to get to know our guests, not just as professionals, but what you do in your personal life as well. So I appreciate you sharing that. I think maybe we can talk a little bit more about how you started working with the principles of trauma-informed care and what your personal connection to it is. And then we can go into what is trauma-informed care.
Sure. Thanks. So trauma-informed care was a completely foreign concept to me when I went to medical school. It wasn't something that we ever talked about. I had never heard of it when I started practice about 20 years ago. And I didn't learn anything about trauma-informed care until I started working with survivors of sexual violence as an examiner with the BC Women's Sexual Assault Service. And just as an aside, we don't see people at BC Women's Hospital. We see them in a number of other hospitals, and we do see people of all genders, just in case there's anybody listening who's interested more in that specific service. But I learned there from nurses, from social workers, and from others about trauma-informed care. And when I started working there, before we start working there, we have to do a 1-week specialized training where we learn some of those principles. And I think some of them were intuitive and things that I maybe had done. And this it gave me some language and a little bit of a framework to be able to understand what I was doing and why. And then some of the concepts were actually quite new to me and required some further reading and some practice and feedback from my peers and my patients to help me understand how I could do those things better. And I mean, I think on that note, it's not like you learn how to be trauma informed and that's it. Like, I think you're always learning how to be trauma informed and how to do better and how to be better and how to relate to people as individuals. And, when we were talking earlier, like, how do you really sort of apply those principles in practice? And it looks different from patient to patient. And so I think I'm a work in progress. I do not have this all figured out by any stretch. But I think kind of having that framework and some of those principles gives you something to anchor your work and your learning and ways of just thinking about how we relate to the people that we work with. And anyway, so that's kind of where I first learned about being trauma informed. And, in the context of working with survivors of sexual violence, in the context of being an examiner for a sexual assault service, we know that when people come in, they have had at least one kind of experience of trauma in their lives, often many more. And so in some ways that's easy in that role, to remember to be trauma informed or to, in that context, it's kind of an expectation. But I think, in talking to my colleagues and in talking to learners, I think the harder part is in all of the other spaces that you work where you may not know that people have a history of trauma and people are coming for completely different reasons. Those are the great opportunities to be trauma informed and to use kind of a universal precautions approach because, the trauma in our society, unfortunately, is so prevalent and so ubiquitous that, the majority of people we talk to will have experienced some form of trauma in their lives. And so if we are trauma informed with everybody, not just in those contexts where we definitely need to be trauma informed, then it's a little bit more proactive, I guess. And hopefully we can apply some of those same principles regardless of who we're working with or where we're working.
I really appreciated that answer. And I think 2 things for me stood out. One was that even as someone who is, practicing trauma-informed care, you acknowledge that it's a work in progress. And I think that's really important for us as future medical professionals to remember that lifelong learning doesn't just apply to the content, like the medical content as we do research, but it also applies to the ways in which we learn more of those soft skills or the ways in which we build rapport with our patients. So I think it's just great to see that someone who is, well into their career, for us as learners, to be able to recognize that there is always room for improvement in the way that I'm interacting and relating to my patients. And it's not always that, I have to have this down 100% before I start residency or before I start my own independent practice. And the other thing that I really liked hearing from you was that trauma-informed care should be just kind of applied broadly to every interaction, because like you said, there are certain context cues, like if you're working in if you're working with survivors of sexual assault, or if you're working with like more marginalized or underserved populations, that kind of lens can turn on, like if you're working in a refugee clinic or things like that, but it should always just kind of be present at all times, regardless of context, because there are people who are not necessarily going to fit those stereotypes or what you imagine to be someone who's gone through trauma, but they can hide it well, or they just don't necessarily fit the classical or typical image of what we think is someone who has experienced trauma. And trauma, like you said, comes in many forms. So I really appreciated that. And with that, I just want to maybe, like you mentioned, even though trauma-informed care is quite fluid and it really depends on the context, maybe we can talk a little bit about that framework and the principles that go into learning about trauma-informed care.
Yeah, sure. Thanks for that. And so I'll just preface this by saying that I am not an expert in trauma-informed care. I've taken my learnings from a wide variety of people and a wide variety of backgrounds and so on. And so what I'll share is grounded in other people's work and other people's ideas, and sort of amalgamated into how I understand it. So I'll preface it by saying that. So trauma-informed care starts with an understanding of how violence and victimization and other forms of trauma impact the lives, and for us as healthcare providers, specifically the health of individual people, and also populations, groups of people and generations of people, and so on. The important part, and I think one of the questions that I often get from medical students, and we touched on this a little bit just earlier, is that it doesn't require a personal disclosure of trauma. And in fact, much of the time, it could be even harmful to ask a person directly, or to sort of put them in a position where they need to disclose previous trauma. Sometimes people will come to you and tell you that they have had some trauma. In the context that I work in, that's the presumption is that if you're seeking care for sexual assault, is that you have been sexually assaulted or have a concern that at least that was a possibility. But so just it's an understanding of the impacts of trauma without having to know exactly whether or not somebody has been exposed to trauma or what specifically that trauma was. So I think that's an important piece. Trauma, of course, can impact people of all genders, of all races, of all ethnicities, of all countries of origin, all socioeconomic situations, sexual orientations, and so on. So it's important that we don't assume, I think you mentioned this earlier, that sometimes we have stereotypes in our head about the types of people that may have experienced trauma. But my point is that it could be anybody sitting in front of you, and you have no idea whether or not, or to what extent, they've got a history of trauma. And so back to that idea of universal precautions, I think, you can assume that because many people do, that it's fair to assume that all people that you come into contact with may have that personal history. Trauma can also be related to one-time events. It can be multiple events, or it can be a prolonged and persistent situation where, people, the circumstances and situations that people are in expose them to, prolonged traumatization. And, one of the pitfalls of Western approaches and of Western medicine is that we've tended to focus on trauma as being kind of the domain of individual people who have undergone some kind of biological or psychological, insult, for lack of a better word. But I think we're starting to recognize, thanks to other ways of knowing and other lenses applied to this work, that trauma can be experienced by families, communities, populations, and even generations of people. And when we think about it this way, it becomes clear that trauma can also be perpetuated by systems of oppression. And so what I mean by that are things such as colonialism, patriarchy, white supremacy, that result in both interpersonal and systemic racism, sexism, ableism, homophobia, transphobia, etc. And those things are all can result in trauma as well. So that sort of helped me to understand the breadth of trauma and the breadth of harm that people have experienced. And again, not just individual people, but groups of people and generations of people. And, obviously those impacts can be enormous on people's health. And certainly that's part of the reason why we see health inequities across populations is, some groups have experienced far more harm than others. I think what all of these experiences have in common and what makes harm traumatic for people is that, whatever it is that has happened, either as a one-time event or that kind of prolonged circumstance, is that it overwhelms the capacity of people to manage that harm and can result in enduring emotional distress, but also those enduring health impacts that we just talked about, and then health inequities between groups. So that's kind of my understanding of what trauma-informed care is. I think there's been lots written in the literature about some of the principles that may help us kind of anchor that and apply that in practice. And we can talk about some of these in greater detail, but I'll mention a few of them just to kind of give us some specific things to talk about. One of the big pieces, this is what I've just been talking about, is just having that trauma awareness. So understanding the ubiquity of harm and trauma, and understanding how that particular trauma or how trauma can impact health. And, so that's an important thing for us to know as healthcare providers. And the impact of that trauma is incredibly individualized. So, no two people that have experienced the same type of trauma will, it doesn't look the same way. The impacts don't look the same across different individuals. So I think also, how that manifests in an individual person will vary a lot, depending on lots of different factors. But just to keep that in mind as well, that it's not for me to judge, something that may sound absolutely horrific to me. That person may have processed that harm and that trauma in a different way, and so may have different impacts than the person next to them. So that's one piece. I think probably at the core of trauma-informed care is safety, and that includes things like ensuring that whatever we do as healthcare practitioners, that we don't add harm to that situation. So, things like just being really aware of our own biases, of our own assumptions, not passing judgment on people. We can talk more specifically if we talk through some cases, what that might look like. But, and not re-traumatizing people, or taking great care to try not to re-traumatize people. So thinking a lot about the language that we use, our body language, the way that we invite people into spaces and so forth, is that our goal is to try to create an environment of safety where people aren't experiencing further harm. And it's easier said than done, I think, in healthcare, because of the really, the intimate relationship that we have with people and the things that they share with us and so on. It's easier said than done. So, anyway, we can elaborate more on that maybe if we talk through some more specific examples. I think another important piece is choice. So often people will enter healthcare spaces and be told what to do, or be told like this is what's going to happen. But I think if you want to be trauma informed, you need to present people with options and choices and be okay with the decisions that people make, regardless of whether or not they're decisions that you would have made for yourself, or, that others before them have made. And so wherever you can, providing choice, providing options, and letting people feel like they've regained some of that control and the ability to choose for themselves what's best. And, we see people as experts in themselves and experts in their own condition. And our job as healthcare providers is to provide information and options and different pathways that people can then choose. And we need to trust that they're able to make, what's the best choice for them in that moment. And then also be open, if people change their minds, or if circumstances change and whatnot, to be okay with that as well, to let people know that it's okay to change your mind, and you may feel this way today, and if you feel differently tomorrow, that's okay too. I guess there's lots of different things I could say here. Another important piece, I think, is that trustworthiness and transparency. So if you say that you're going to do something, do it. And if, and just being really transparent about, do what you say and say what you do kind of thing. So people know that they can trust what you've said. And if you make a commitment to something, follow through on it. And if you can't for some reason, then you need to explain that and to let people know why that didn't happen, and so on. Just to build trust, and to build, you need to be a reliable and trustworthy person in that healthcare space. That starts with exactly doing what you've said you're going to do, and telling people what is happening, so that there's a level of transparency. People understand why things happen a certain way, and why you're asking about certain information, and so on. So maybe enough said about that. Also, that notion of collaboration and mutuality, like people are partners in the healthcare space. And I think quite often as healthcare providers, we forget that patients are really at the center of the team. They're the ones making important decisions about their health, and it's our job to provide information and to empower people to be able to make informed choices. So arming people with information and opportunities and so on, and seeing patients as partners in their own journey. And quite often, again, it's sort of us dictating care, or us telling people how things are going to happen, rather than sitting down together and saying, how can I best support you, and what do you need in this moment, and so on. And I think kind of at the bottom of this is, we tend to, in healthcare, we tend to, consciously or not, and overtly or not, we often blame people for their poor health. We think, well, they've been making poor choices for their health, or, they've done X, Y, and Z. How could they think things would have turned out differently? But when we think about some of those bigger systemic pieces, I think it helps us understand that, we don't often, and not all of us have the agency that we like to think. And so poor health is often shaped by circumstances well beyond the control of the individual. And so we need to be really, really careful that we're not we're not putting the blame on individuals for their poor health, but rather, supporting them where they're at and thinking about some of those bigger system issues that may have played a much bigger role than any individual choices that person has made. And finally, I think for me, what grounds all of this is compassion and humanity and love, like not in the kind of, romantic or sexual way, but just like caring deeply for other humans and trying to connect with people on that human to human level. Again, it can be really hard. Like we have busy days in healthcare and lots of things to do and lots of things to get through before we can leave and go home to see our own families. And so, it's kind of just an important grounding thing sometimes, just to stop for a second, take a deep breath, and remember that the person sitting in front of you is another human being who may have endured a lot in their lifetime. And, it's just a reminder to kind of put aside like some of those other things that we sometimes worry about or feeling, really, we've got such a sense of time pressure in our system. And it often doesn't take a whole lot more time, but just that reminder and kind of being conscious that, this it's another human sitting in front of you and another human who may have endured a great deal of harm and trauma and suffering. And so, what can I do in both as an individual practitioner and what can I do as, a member of the healthcare team to help make that person's experience more humanizing and more kind of reflective of, what the service that we want to be providing as healthcare practitioners.
I think those are really good principles to incorporate into our practice, especially as we, for more junior learners who are just starting out, to be aware of these beforehand is really helpful to just have it on the go. I think a couple of the themes I heard from this in the principles is one, how you mentioned that trauma isn't necessarily happening to a single person at a single point, but it can be one of the terms we use is like intergenerational trauma. And then that kind of relates back to what you were mentioning about how individuals don't necessarily have all the agency we would like to think they have over their health condition and the quality of their lifestyle. Like we talk a lot about in medicine with like lifestyle choices and lifestyle modifications is a lot of our first line treatments for a lot of different conditions, but it is important to think about, okay, well, if someone is working, 2 jobs to be able to afford rent in Vancouver and groceries, is it really feasible for us to expect that they can also work out or engage in exercise 30 minutes a day and also, tend to their mental health and tend to their children? So it is really important for us to not think about all of these things that we're recommending in a vacuum. We, even as people who see patients in the hospital, we're only really capturing maybe a week. Most often, if it's an outpatient clinic, 10 days of their whole life. So I think for me, it really helps to contextualize if I was a patient, what would I be able to implement all of these things that I'm recommending to someone? And is it realistic of me to ask that? And the other thing that I heard was really changing the narrative so that the patient is the captain of the ship. And we as healthcare practitioners are the navigators because we know the medical knowledge, we have the medical knowledge, and we know how this healthcare system works. So the pathways that we can provide, but that choice should go back to them. And a lot of that goes back to the communication that you were mentioning. And I like to give concrete and tangible actions to learners that they can do. So something that I do that when you were talking about communication and transparency and reliability, something that I like to do, whether it's when I'm on family practice or on CTU or surgical rotation, when after going through my history and physical, if I had come up with a plan, I would go through what our kind of differential is or whatever is our provisional diagnosis and kind of explain that, especially with some of the more complex internal cases, internal medicine cases. It is a bit hard for people to wrap around the concept of like, what is ascites? What is heart failure? What does that mean? Like, what happened to my heart? So like really putting those into like not avoiding using jargon and putting it into terms that people can understand, and also then laying out a plan and letting them know that these are the options we have, these are the tests we're doing, why we're doing these tests, and how it's going to help us come to a better plan for them at the end. And I think that's really helpful of just kind of, this is probably going through every learner's mind, like every medical student and resident, like they're making those plans in their head as they're interviewing or seeing a patient, but it's important to communicate those before you leave the room. I found that really helpful when I've been on the other side dealing with a family member who has a chronic condition. So I think it's really helpful to see the other side and realize, okay, well, I know that there's a plan, but if it's not communicated to me as a patient or as a family member of a patient, then I've kind of feel like I'm left in this very difficult time and a vulnerable time without like kind of anything to hang on to know that there's a plan. And I definitely appreciate, again, being on both sides. I know when we don't hear back from a physician or from the care team in general, it's because they are so busy. But when there is that time for them, they put that time aside, I really do appreciate it being on the other side. So that's something that I like to incorporate in my practice as well, just because I know it does really, it means a lot to the patients.
Well, and even including the patient in developing that plan, because, the smartest group of healthcare providers can go and sit down and come up with the greatest plan. And then you come back to the patient and it's like, no, it's not going to work because of X, Y, and Z, or that's not what I want, actually. Like my goals are totally different than what it is that you're talking about. And so I think, taking the time to understand like what that person's healthcare goals are and, what the possible care options are and kind of plan pathways could be, and then incorporating that perspective when we're coming up with some of the options and so on.
Yeah, really making that, like you mentioned, like partners process, like partnership, and you work together, because you're right, we could come up with an amazing plan that works in a textbook, but if it's not aligned with the patient's goals, then it's not the ideal plan.
Yeah.
And the other thing I will say for medical students, something that I really was surprised is at how much some patients, and this is quite patient dependent, but some patients do really enjoy learning about what you are doing. I remember one time I was on call on CTU and I wanted to do a POCUS exam for a volume assessment, and I brought in the ultrasound and I decided, like, I had some time that night and I was like, would you like me to like talk through what I'm doing? And we ended up actually talking through it, and this person had some connection to the medical world, so they found it quite interesting to learn what's exactly happening. And it really built a great relationship, and it really didn't take that long because I was going to do this assessment anyway, but it helped us build a nice rapport. And in the time that they were, again, quite vulnerable and they were worried about their health, they were sitting in the emerge, it was a good distraction for them, and it really helped, I think, have a close relationship with that patient in that time. So I do really recommend just being transparent. I think it's hard, especially as you're starting maybe clerkship. It's harder to remember everything that you need to do and also incorporate the patient. But as you start getting more comfortable with your history taking and with your physical exam, try and incorporate those skills into that as well. It's something that I really found helps with making patients be a bit more at ease. So we talked a little bit about you teased a little bit about like what are some specific cases that we could go through. So maybe from your experiences, if we can talk through a typical patient interaction. I shouldn't say typical, every patient interaction is kind of different, but some of the phrases and some of the situations that you encounter in those interactions would be really helpful. So for our learners, so that they have kind of a repertoire of vocabulary and questioning that they can use that is that has been shown to be helpful in more sensitive situations.
Sure. So, I mean, maybe a place to start is sort of the obvious. I work at the sexual assault service. We see people acutely following a sexual assault. And so that might be an obvious place to start, because it's somebody that's coming forward with a disclosure of trauma. And maybe we'll start there. I think certainly the first thing that, like, I think there's ways to frame or reframe the medical encounter and to reframe some of our tasks to be more trauma informed. And so, to give you an example, I think we often take a bit of a deficit approach with people, and we think, like, what's wrong with that person? Like, why are they behaving in this way? Or like, why can't they just like behave like everybody else in this, waiting room kind of thing? But instead kind of reframing that to, what's happened to this person? Like, what this, the trauma that happened must have really had a huge impact on, on their ability to, to do X and Y and so on. And kind of thinking about reframing patient behaviors and so on in that trauma-informed way. So for somebody that comes in following a sexual assault, thinking about options. So, and choices, asking them what is their biggest concern? Like, what is the thing that we need to make sure that we're addressing before they leave today? And often their biggest concern is not the same as my biggest concern. So I need to then kind of park my own agenda. Not ignore it, because I think, we think of these things for a reason, and they're important to keep in mind and perhaps bring into the conversation. But ensuring that the person sitting in front of you, has an opportunity to let you know what's most important to them, and then following their lead. So in the example of sexual assault, they may be most worried about how they're going to tell their spouse that this has happened, or they may be most worried about the fact that the person that assaulted them is their employer, and what is that going to mean in terms of their continued employment if they seek care, or if they report what's happened. Will they be able to pay their rent and put food on the table next month, as an example? Maybe they're worried about an infection or an unintended pregnancy, or any of those things. And so just understanding what that is, so that we can attend to that and make sure that we're offering support and resources and, in some cases, treatment for whatever it is that's of most concern to the patient. We also, and people don't often know this, and I think a lot of people don't seek care for sexual assault because they don't understand that there are a lot of options. So people assume that if you come to hospital seeking care following sexual assault, that the police have to be involved, for example. And that is one choice or one option for people, that, we can help them report to the police, or we can help them do like a forensic exam, and to store that just in case at some point in the future they do want to report to the police and so on. But those are all patient choices. So, that's not anything that we have to do. And so just presenting a variety of options. We can do things in whatever order people want. So sometimes people come in, they want an exam, or they want an injury assessed or something like that, and it's the thing that they're most worried about. if we leave that till the very end of the visit, they've been sitting there worrying about that through the whole visit. So giving people the choice of, what would you like to start with? Sometimes people come in and they haven't eaten in days, or they haven't slept in days, or they haven't had a shower in a long time, or, for a variety of reasons. And so sometimes that's the most pressing thing. And so, it seems so simple, and often we kind of see it as not something that we do as physicians or as healthcare providers, but wow, it goes a long way if you can offer somebody a sandwich or warm blanket, or, something that is meeting that immediate need that they have. And so, again, kind of being a little bit flexible in, how we're approaching things, and providing lots of options for people. The other thing I wanted to talk a little bit about was being inclusive, and particularly kind of our language choices around inclusive language. And so we make a lot of assumptions about people based sometimes on their appearance. We make assumption based on, what's in their medical record. But, just being open to, being proven wrong, that your assumptions were wrong, or that, things, people may be like not what you had expected based on what you had read in their medical chart and whatnot. So, just trying to be inclusive in terms of people's gender, in terms of their sexual orientation, not making assumptions about, that somebody, their marital status or their immigration status, all of those kinds of things. So, just trying our best to be inclusive and to be thinking broadly about, who this person is sitting in front of you. In the specific arena of sexual assault, I think using language of violence and assault rather than language of consent, I think is really important. So to give you an example, rather than saying or asking the question, did he kiss you? That's the language of consent. The language of assault, or language of non-consent, is, did he force his mouth anywhere on your body? There's a big difference. And so it may seem subtle, it may seem like a silly thing, but, I think in one case, it can be really invalidating for people to, that we're talking to them as if they had consented to these things, when in fact they have been, at the receiving end of a violent crime. Another language piece that I think is important, and again, it may seem like a really small difference, but I think it changes the narrative, is whether or not we call somebody a victim or a survivor of trauma or of violence or of sexual assault, or whatever the context is that victim kind of denotes that, people are passive, that they don't have any agency, or that, something was done to them. And survivor has a bit more of a strength-based approach. And so I think, it can make a lot of difference if we're thinking of people as survivors rather than as victims, and trying to use that language as well. And maybe to kind of contrast that with an example where we don't have that obvious trauma disclosure. So, one example that often comes up is, as a family physician, perhaps you're sending somebody for a procedure, maybe colonoscopy or some other invasive procedure. And, we may not understand the kind of impact that procedure can have on that person, particularly if they have a history of trauma and, particular types of trauma. And so, if you're the person who's going to be doing that procedure, or, you're just meeting this person for the first time, you don't know anything about them, it may seem like, let's say you're going to be doing a colonoscopy and that person seems unusually anxious, or, you kind of proceed in the way that you normally do, but, there seems to be like a number of barriers. I think if you can think to yourself, this person may have had a history of trauma, and what are the ways that I can approach this that doesn't require disclosure of trauma, but may help me understand where this person is coming from, or like what this experience might be like for this person. I think it just gives us so much more understanding and patience and, compassion for that person, rather than, kind of rolling your eyes and thinking like, what's the issue? Let's get on with this. I think that, those kinds of things are, they present themselves that way all the time. Or, as a medical student or as a physician, you're seeing a patient on the ward about something seemingly quite benign. Maybe you've been asked to assess them for hypertension or whatever it might be. But the language that we use and the way that we approach that person needs to respect that they may have had negative encounters in the past, or have been the survivor of, repeated trauma and whatnot. And so, I think my point is just that I think we can apply those trauma-informed principles regardless of whether or not we're in a situation where there's that disclosure, or if it's something seemingly completely unrelated. I think, that still applies. In terms of what I was saying earlier, I think just trying to reframe things. We often in medicine are taught to see things through a bit of a deficit lens. We see people who, for their deficits or for the things that are kind of going wrong, or the way that people are acting that is seemingly a barrier to providing healthcare. And instead trying to reframe that and understand why that might be, and, how we could approach it instead. So as an example, sometimes somebody might be behaving in ways that we see as manipulative. Perhaps they're, saying one thing to one healthcare provider and, another to another person, or trying to kind of negotiate things and so on. And instead of framing that as manipulative, which is pretty deficit based, is, clearly this person is having some trouble with asking for what they need and want directly, maybe because of previous experiences or some trauma in their history. What are the ways that I can change my approach that makes it easier for that person to express their needs? Sometimes we call people, we use the term borderline to describe somebody who, may have some challenging interpersonal behaviors. And instead, if we're thinking, what happened in this person's early childhood that, developed these ways of seeking care that may seem less adaptive. But if we then think, if we consider, and again, without requiring a disclosure, but, perhaps this person had a really difficult early childhood where they had a lot of insecure attachments and didn't have their needs met. It's then much easier to understand why those behaviors are a pattern, and how what is our reaction to that? Is there a way that we can frame things in a different way or ask questions in a different way or behave in a different way that helps that person to, to create a place where there's trust, where there's safety, where that person knows that you're going to do what you say you're going to do, and it's going to be transparent. Doesn't mean we have to give in to every demand, but it really helps to reframe what it is that we're seeing and how we can adapt our care to be more understanding and more trauma informed. That makes sense.
Yeah, I think a good way to kind of conceptualize that, it reminds me of a topic we covered in like first year of undergraduate studies in first year psychology. There was this kind of two ways of attributing behavior. One is situational, and then the other is personality. So, for example, if you see someone run a red light on the street, some people, if it was a stranger, they would attribute it to their personality. So that person is a bad driver. But then in a different context, if it was someone that they knew or if it was themselves, it would be situational. I was late to my doctor's appointment. I was late to pick up my daughter from school, something like that. So I think it's really important for us to see, and from what I'm gathering from this is that it's that mind set switch and reframing the situation to attribute behaviors to more of a situational origin rather than a personality or something that is fixed. So considering what this person has had experiences with in the past, what are the experiences they're having now that are maybe pushing them to behave in this way, rather than, oh, this person is borderline or whatever, and they're always going to behave the exact same way in these situations, and that's never going to change. So I think that allows us a lot more room for us to adapt our own behavior as well and our own reactions to the patient if we believe that this person is capable of changing their behavior based on the situation. And it's an easier way to build rapport, I would say.
Yeah, and that we give people the benefit of the doubt that they're behaving in the way that they know best, or the way that that they've had to behave in ways to get their needs met and so on. It helps to just build that understanding. So I think that's a good analogy.
Was there anything other that you wanted to talk about specifically with regards to language, or anything that would be important in the specifics, or we can also move on to a different question?
So, I mean, I think we've maybe talked about some of these things already, but just being careful how we frame things, that we can often come across really judgmental in our questioning of people or in our sort of history taking. So to give you an example, if somebody comes in following a sexual assault and we know that there's been some alcohol involved, we might ask them something like, well, how much did you have to drink? Or, well, why were you drinking? Or why were you wearing what you were wearing, or whatnot? And the implication is that somehow what happened was their fault based on what they were wearing, or that they had some alcohol. And if we reframe that and say, well, we should be able to wear whatever we want to without fear that somebody is going to commit a violent crime, or we can all expect that we should be able to go out with our friends and have a few drinks if we choose to do so, without suffering the negative consequences of somebody else's behavior. Then reframing that, we might say, we might ask the person, is your reaction to what you drank out of keeping with what it normally would be? So in other words, people sometimes say, yeah, I can have a few drinks and nothing happens. Nothing, I'm fine. And in this case, I had one drink and I don't remember anything else. Or, it helps to reframe the encounter from one of judgment, where we're implying that they've done something wrong, or that the behavior that they chose led to this trauma, and rather, trying to understand the impact of what happened without judgment or without blame on that person. So I think they seem subtle, but I think important changes in language that to take a lot of care that we're not passing judgment or implying that if somebody's been the survivor of a violent crime, that somehow it was because, that it was their fault or because of something that they had done or not done, rather than, the actions of the other individual involved or the other individuals involved. The one last piece I'll say, this is a bit of a pet peeve of mine, is that we like to label patients sometimes as difficult, as a difficult patient. And again, if we're trauma informed, you can have a difficult encounter with a patient, but that doesn't make the person a difficult patient. It means the encounter was difficult, probably because of the interaction from both sides. And so, thinking to yourself, what about this is difficult? Why is this difficult for me? And how might I be contributing to making this situation difficult? Thinking about the person that you're talking to, instead of thinking what's wrong with this person, what is it that might have happened to this person, to have them engage in these types of behaviors or to have this pattern of interacting with people. Might they just be trying to get their needs met, and we haven't yet met them? So what can I do to meet this person where they're at and to understand what those needs are, and then, work out a way that those needs can be met, rather than labeling the person difficult. I think it's really harmful when we do that. And kind of back to what you were saying before, we have now kind of attributed, we've labeled the entire person as a difficult person, as part of who they are, rather than to identify a particular interaction with that person that was difficult for us for a variety of reasons. And why was that difficult? And what can I do? What might I have done to contribute to that difficulty? And can I reframe my approach to make that interaction less difficult? And often, I think in healthcare, it's the person's way of letting us know that we're not meeting their needs. And with some people, it's a pattern of we repeatedly haven't met that person's needs. So they're not a frequent flyer. There's somebody that is not having their needs met. We haven't yet figured out how to meet their needs. And so, again, kind of reframing it to be something that we can impact in the way that we approach people and the way that we offer people care and present options for care.
Yeah, and I'll say this actually kind of reminded me of a patient story that one of my friends shared with me, and this is a really good opportunity, I think, for medical students to advocate for their patients when they do get labeled as a quote-unquote difficult patient. My friend, they had a patient on one of their rotations who was deemed as a difficult patient, and because the reason was because there was a procedure that was recommended, but they just had more questions about the procedure than the team, I guess, had time to answer. But getting that label does have really negative implications for the care that the person receives, because it's almost like the team becomes sensitized to every little maybe question, or not even a challenge, just wanting more information becomes this affirmation bias of oh yeah, this patient is difficult, so then you start spending less time with them, so their needs are even less met, and then it kind of keeps going. But in this situation, my friend was able to advocate for their patient and ask the we actually chatted about this. They said that it wasn't something that they felt comfortable answering. It was really specific questions specific to that procedure. So they were able to bring someone with more knowledge from the team to get those questions answered. And it was, it's a very good example of like how a reasonable request can be maybe ignored or delayed because this patient had in their chart, they were deemed difficult from a previous experience. And so people weren't paying attention to how we could meet their needs. And again, I think a really good example of where med students, even maybe they don't have all the knowledge to be able to answer those questions, they can advocate and find ways for that questions to get answered and ultimately have better care.
Yeah, thanks for sharing that.
And then I was going to maybe chat a little bit about how do you think your practice has changed since starting to use the trauma-informed care principles and how your relationship with patients has changed?
Yeah, that's a really good question because I think that's the crux of it, right? I mean, we want to be what we talked about at the beginning. We want to constantly be improving our practice and providing better care and thinking about, what are the changes that we can make to be better at what we're doing and to provide better care and to have patients experience their care in a better way. For me, being trauma-informed and practicing being trauma-informed, again, it's a work in progress. It completely changed my practice. It has given me so much more understanding. It's given me so much more patience. It's given me so much more appreciation for where people have come from and what kinds of things that they and sometimes I've been privileged enough to have patients confide and disclose parts of their history, and sometimes that they haven't disclosed to others, and which is a huge honor, it feels like, and a privilege. And even in cases where they choose not to disclose, I think it's just given me so much more just appreciation of seeing people, meeting them where they're at, seeing them for the strengths that they do have, giving us both hope that, people can and do, make changes in their life, and make choices that, kind of given the right situation and the right circumstances, can have a really big impact for them and for their health. And so, I think it's just totally helped me to reframe that. And I hope that that's resulted in better care. It certainly has resulted in way more professional satisfaction for me, like way less frustration, way less, kind of that feeling of like, we're not getting anywhere here. This person is manipulative and those kinds of things. And just being able to reframe that and say, okay, I need to approach this in a different way. And what skills do I have that can help me reframe this encounter and help, support others who are part of the care team or who are part of this patient's journey to see this in a different way. So what are the things that I can do to help pave the path for this person, for the next person that they're going to see, that will make things easier for both parties? And I hope and I think that it has definitely strengthened my relationship with patients in being able to provide a safer and more trustworthy environment, and knowing that when I say something to somebody that I'll follow through on it. And if I absolutely can't because of something outside of my control, that they trust that I'll come and talk to them about it and let them know why and explain and, apologize if it's something that I have overpromised or something that, I might have done differently. I just think it helps us relate to each other as humans. People, we absolutely need to see our patients as humans. And if they can see us as humans, I think it's helpful too that, people then have an understanding, why things have gotten a certain way, and a lot more patience for, why things happen the way they do. If we can just have that kind of relationship with people. So, I think it's been really, really rewarding for me, and I hope that the same is true for my patients, that I have been able to provide choice and dignity, and to give back some of that control that sometimes people have lost or feel that they've lost when they enter the healthcare system, and are kind of constantly being told what's going to happen or what other people are going to do to them, and instead make them feel like a really important part of the care team, and that their needs are central to what's happening, and that there's an understanding that, they may have experienced things in the past that have led to where they're currently at, but that it doesn't have to be perpetuated, and that care can look different for people, including for the providers. And, in this day and age of burnout and just that kind of emotional exhaustion and that kind of thing, I think it's increasingly important that we, that we're doing things, of course, that are going to benefit patient care, but also that are going to increase provider satisfaction, and, to feel like there's meaning to your work, and that you're making an impact and making a difference in the lives of people at the end of the day. Because I think, that's what draws us to this work, is that, we want to see people lead healthier lives, and so on. So anyway, those are the benefits that I've seen from being trauma informed, both, hopefully from the patient side. Of course, I can't speak for my patients, but certainly from the provider side as well.
That's actually something that I hadn't even thought about, of like, when you change your mindset, it's not only towards the patients, but it's also towards yourself, and what the work that you're doing is not working with the quote unquote difficult patient or the borderline patient, but someone who has gone through trauma and gone through life experiences that you don't know about, and you're coming together in a partnership. And I can see how, at least from our perspective as the providers, that mindset switch is so helpful in the work that we do, and makes it a lot more meaningful and rewarding, like you said. And then just to switch gears a bit, in your other role as a medical educator, can you tell us a little bit about your experiences in teaching medical students and medical learners in principles of trauma-informed care?
Yeah, sure. And I've been thinking a lot about this, because I do a session in first year specifically on sexual assault, and there we talk a lot about trauma-informed care. And when I first started doing that, I think it may have been the only place in the curriculum that students heard about trauma-informed care. Of course, unless they came from a background in social work or nursing or whatnot, and then their expertise likely far eclipsed mine. But I think it's becoming more and more common. So I know that now at UBC that it shows up in many places in the curriculum. So that's really exciting. And, it means we can maybe push the envelope and build on that, and go a little bit further than we've been able to in the past. It sometimes runs a little bit counter to some of the other ways that we do things. Like I think we talked a little bit earlier, that we always seem to be under these time pressures. Like the entire healthcare system is built on like time pressure and rushing and never having enough time to catch your breath. And so I've been thinking a little bit critically about like why that is. Like why do we accept that that's the way things are? And for medical students, like why are we putting medical students under these incredible time pressures almost artificially? When you're learning, like it takes time to learn, and it takes time to sit down with patients and get to know them and all of those kinds of things. And so I think it's important for us to be teaching about trauma-informed care kind of didactically, But then we need to also kind of think critically about the hidden curriculum and what are students learning from us in the clinical environment that may not be very trauma informed, and how can we change that? And so, and again, that's a work in progress, something that I think about a lot, but isn't always so easily enacted. But anyway, and even talking about some of those disconnects with students, I think is helpful. That gap between sort of the ideal thing that you're learning about in the classroom and then what you see happen in an actual healthcare setting. When those things don't align, it can be really distressing. And so, places like Portfolio, for example, are a place to talk about those things. Like, why is this causing me this kind of distress, and what's happening here that, I'm trying to be trauma informed and I'm seeing this other thing happening. And so, helping learners to process that. And then I think ultimately trying to shift that system so that there isn't that disconnect, so that what we're doing in practice are the things that we're kind of talking about in the classroom as well, and bringing those things into greater alignment. That's, again, a work in progress and not the work of one person. And then finally, I'll just say one of the things that I've started to think a lot about with some of my colleagues is how we can be more trauma-informed in our education practices. So I know, and I have known for a long time, that when I get up in front of a class of 288 students and talk about sexual assault, that there's going to be a huge number of those students that are going to have been directly or indirectly impacted by sexual assault. And how do we navigate that space? And are there things that I can be doing and that the program can be doing to make that a safer learning for those students that have been impacted first and foremost, and for everybody? And there isn't an obvious or easy answer there, but I'm starting to think more about trauma-informed education practices and what are the things that we can do as educators that honor and kind of understand that our learners are humans too, who have experienced trauma of different kinds. And, what are the ways that we can teach about these difficult topics and teach about trauma without or minimizing additional trauma to learners? And I don't think there's an easy answer there, but I think other fields are further ahead. And so what are some of those practices that we might import into health professions and specifically into medical education that will make education less traumatizing for our learners? And so maybe that's an episode for a future podcast, is how can we be more trauma informed as educators and as sort of on the ground educators who work kind of face to face with students, but also as people who are designing curricula and designing programs and so forth. Thinking about, how can we infuse some of those same principles into education? And maybe I'll leave it at that, but definitely some food for thought and something that I've been thinking a lot about.
For sure. I think as I, go through making this podcast, it's very interesting to see where our own lives, our personal lives and our own experiences kind of intersect with the things we learn about in our profession. So the things that I've covered previously in different topics is, people with lived experience of gender affirming care who work in gender affirming healthcare. How do they balance things that can possibly be triggering for them, or people who've had eating disorders, trying to see patients with the same thing and kind of balancing our own lives as people who've gone through different types of possibly traumatic experiences, and also seeing those in person. So I think it's really great to hear that there's thought about it.
And I think
in medical education,
you've touched on something really, really important there, and that is that we're all humans and we come with all of our own background and baggage, and many of us have experienced different types of trauma, and trauma to different extent. And we carry that with us, and it impacts the way that we see the world and the way that we interact with patients. And it takes a lot of work and a lot of healing for us to, to process that and to, just to heal from some of those things. And, in order to be like taking care of ourselves and to be, doing all the things that we need to do for ourselves and, in our personal lives, but also then in our interactions with patients. And we know that medicine is full of people with trauma and often people with unhealed trauma. And we need to think about, how that might be, it can be an advantage, I think, because we can relate to people, and it can also perhaps perpetuate, if we're not aware of it or if we haven't started to process it or to get support in sort of navigating it, it can perpetuate itself in other kind of less productive ways. And so, something for us to be thinking about as a profession, right? Like they say, physician, heal thyself. And so thinking about that both kind of on the individual level and on as our profession as a whole. Are there things that we need to be doing to care for ourselves in, putting our own oxygen masks on first, and managing some of our own trauma before we can be effective in helping other people managing theirs. So some food for thought and maybe a good place to leave this conversation.
For sure. I think that could be a whole podcast episode by itself. Just to wrap it up, I just wanted to see if there's any pearls that you want to leave our listeners with, to takeaways from the podcast, from this episode.
Yeah, I mean, I think if it's anything, this takes practice. And like we said at the beginning, I am not an expert in this. I do not do this perfectly. It's something that I'm practicing over and over again to try to get better at it. So that would maybe be my first pearl, is that like keep practicing. You're going to make mistakes, and that's okay. And it's okay to say to somebody, I really don't like the way that what I just said. I didn't mean it to come across in that way. Can we back up and start again? Those kinds of things are okay. Like we're human, we make mistakes, and and provided we're learning from them, then, I think it's okay. We need to be thinking about our language and, the words coming out of our mouths, but also our body language and the way that we carry ourselves, particularly when there's patients in our midst, and just to be thinking about what patients are seeing and hearing from us. I don't know. And I guess that reframing would be the other thing. Like, is there a way to reframe this encounter? And there's stuff written on this in the literature. So these aren't my ideas. These are things that people have written about. But if there's ever an opportunity to reframe an encounter, I think it just results in better care on both sides. I think it's better for patients, and it leaves us feeling at the end of the day that we've done a better job. And, I think we all want to feel like that at the end of the day, that we've been able to help somebody achieve their health goal or to work towards their health goal. That there's sort of purpose and meaning in what I do. And so, maybe those are the pearls for today. And,
I appreciate that I think those are really good takeaways to have. And with that, I'm really happy that we got to have a chance to chat. Thank you so much for coming on, and thank you everyone for listening. I hope that was something that you can apply to practice, whether you're just starting clerkship or you're already in residency. Thank you.